Another long drawn season has actually come to an end, finally, with the exam happening on the 3rd of August 2025. And we are here with this recall. I think we've been doing recalls, I think, as you know, a lot of them, lot of them. I just primarily reiterate on that quite a bit because of the reason that many of you may ask your seniors who may be just 1 year senior to you. So you have an idea of the exam for maybe 1 year or 2 years. But since I've been doing recalls for a long period of time now, so I think I've just seen through the different stages of this exam and how the exam has progressed and all that. So it's always been unpredictable to say the least. It had a pattern for 3 years from 21 to 23. Then 24 was a total bouncer, big surprising exam. And in 25, we've had a very, very, very simple exam with few controversial questions here and there. But on the whole, extremely simple for people who have actually done their basics well, revised well. I think it's been a pretty straightforward walkthrough. Few questions are pretty much controversial. It's very hard to actually draw conclusions out of those questions, primarily because I haven't written the exam myself. So if you just twist a word here, there, if you just change a reference here, there, the answers can change. So I have just tried to express my opinion on that as well. But we just scan through a lot of questions that in fact come from medicine. If you look through the total medicine and allied, the total number is around 65 questions, which is a huge number out of 200. But majority are very easy and very straightforward. Now, the biggest concern that we have when we face an exam like this is this question as to really whether you need to work so hard. Is hard work really the key to success in an exam like this? Now, the basic misunderstanding that I feel, or perception issue that I feel exists over here, is people tend to associate working hard with, what do you say, shutting out from everything else, sitting in a room, not going for any family function, being with your book and sitting and reading. So this is what people associate with what is called hard work. But actually speaking, that is not hard work. That is kind of punishing yourself. What in real terms we mean hard work in medicine as such is the ability to toil inside a ward. That is called hard work. So hard work, when you are looking into with respect to this exam, that much of working hard was not required, because if you look at a person who was invested 2 3 years in sitting and preparing, another person who has randomly read few stuff here and there and gone and written the exam, I wouldn't think that there is going to be much of a difference, because majority of the questions are at a very superficial level. So if you have written all your university exams properly after watching a few reasonably good videos and then got reasonably good marks in your university exam and revised that and gone, I think even with that you will be in a very competitive level as far as this exam is concerned, and the margins are going to be literally very narrow. But that is never a reason for us to step back from what we have been doing. So once we are having faith in what we are doing and we are consistently putting efforts in that direction, exam trends might change here and there. One exam might be like this, one exam may be like that. So that's not our concern. But all this will augur really well for us, because we're studying well, we are in the groove, and we are actually going on with the work. The IN exam is going to come, then another IN exam is going to come. So somewhere along the line, people who have actually studied solid will be able to really get out of that. And even in this exam, I feel, though the number of tough questions or the controversial marginal questions, they're all actually on the lesser side, you still feel that they're going to make a lot of difference, because I can figure out myself 5 or 6 questions from medicine. On the whole, you can actually figure out, say, 13 14 questions. I feel at the end, those are the questions that may actually determine who is going to break through into the first 2000. It's quite impossible to draw a conclusion before the results, because I feel people who have studied genuinely might actually even go above 185 190 in this exam. Let's see how it is. That's what I feel. And then for every mark, there is going to be considerable crowding, and probably even in a matter of 1 or 2 marks, a lot of things can change. For this exam, there is no much use in talking about strategies, and I don't believe in strategies right now, because this exam and the last exam had nothing to do with each other. So we made a lot of strategies with respect to the last exam, and does it really hold true here? Doesn't hold true here. So the next exam may be similar to this one, or maybe totally different. There are a lot of people who are trying to do the same thing as what we are. So it's a matter of very few margins, of very few numbers. So if you're trying to punish yourself or being very strict with yourself for missing out by a very narrow margin, I think that's not the way. I mean, that's quite a bit of injustice, I believe, and that you are actually kind of doing on yourself. So please be a little bit more liberal with respect to that. We are all studying in an exam where you really want to make a mark with respect to your ability and knowledge. This is not that kind of an exam where majority of the questions are easy. So you can just try and hold on. Hopefully you've done all the basic questions right. You haven't got silly mistakes. You're still in with a very, very good chance. and few questions controversial, which obviously we'll see. And there the answer can go either way. That again depends on the national board, it depends on their reference, it depends on the actual wordings and a lot of things. And what's in stock for the upcoming exam? No predictions, absolutely no predictions, because INA has more or less followed a pattern, but even there I believe we've had bounces if you observe the exams over the last 4 3 4 years. But my only request is, because this exam has been along this particular line, never ever think of making your study plan diluted, or never ever think of trying to study few basic facts and trying to make the learning process very simple. Diluting your study plan and trying to just focus on few revision concepts here, there, etc., may not actually help you to cross the bar and come forward. Because what really matters is, even this exam and then going forward, is for you to actually come into the mainstream. That is what the whole idea about the exam is. Many people are asking the same question, why this exam is so hyped up, and I myself have said this is like the rate limiting exam in your career. Why? Because of the reason that this is your chance to come to the mainstream. Majority of you are not in the limelight, you are not in the mainstream, you are far away from the mainstream. How to come to the mainstream, how to make a name for yourself, how to come into the reckoning, how people will identify you as Dr. So and so, this is your chance. Let's like go to the questions again in a chapter wise format for the ease of understanding. We start off with the major chapter as always. Maximum number of questions this time also has come from endocrinology and metabolism. That's general rule in this exam. Let's see what are those questions one by one. This is the first question. Again, not much of a doubt. Their clinical questions this time were very much like towards a diagnosis. They never wanted to create any confusion with respect to diagnosis. So they were just trying to give a lot of data for the student to be very clear with the fact that this is this, etc. So a lot of data to just tell you that this is a DK, and they're just checking out on whether whether you have managed or whether you know how to treat a DK. And basically, this is very simple stuff, and anyone who has actually done his internship from anywhere in the country would be able to answer this. There is absolutely no role for 3% NS in the management of DK. 3% NS is something that you use for acute hyponatremia, and you've discussed about the role of 3% NS in acute symptomatic hyponatremia happening within the first 48 hours, and wherein we look into the benefit versus risk of giving a patient 3% NS. And if you feel that the benefit is more than the risk, then of course you can. And we have discussed about 100 ml 3% NS, how to give and all that. So a very basic level question to start off with. This is the management of DK. As always, this is an important topic. I think the take home message for people who are preparing for the exam is that every time there's a question on complications of diabetes, the acute complications, the question has been centered around DK. So DK module is very, very important. Second is a pituitary question, where again all the features are very, very much like in favor of acromegaly, and they've asked about what is a confirmatory test. We've discussed this time and again, time and again. I can see the slide where the screening test is IGF-1 because it is having a long half-life and it is non-pulsatile. And of course, the whole most important test that we keep on discussing again and again and again is this growth hormone suppression test. That means 75 gram more of glucose load, and if your growth hormone levels are being suppressed to less than 1 nanogram per ml, that is actually out. If it is failure to suppress to less than 1 nanogram per ml, is basically equal to acromegaly, and this is because of hyperglycemia and somatostatin. All this we've discussed in detail, and then we go to the imaging, which is your MRI, and you look into the T1, T2. It's a macroadenoma that you get there most importantly. So this is a question. So no suppression of growth hormone after glucose administration. So some people, I think, unfortunately, kind of thought about suppression of IGF. It is not suppression of IGF, it is suppression of growth hormone. So it happens if you kind of mug up and then there suddenly you go and you have a confusion. But people who have known this properly, the screening test is IGF-1, and then you give scientific grams of oral glucose and you check for growth hormone levels, and growth hormone levels less than 1 nanogram per ml is suppression. If you're not able to suppress this, then that is equal to acromegaly. It's very straightforward. I think majority of people got this right as well. Question number 3 is again with respect to metabolism, where again we have talked about this in detail as to why we shouldn't be correcting or over correcting. Previously per day we used to correct up to 10. Now we say even 8 to 10 is max to max that you can correct. And many a times as a house surgeon, you would have seen your PGs talking about this, that how much ever we try to correct in the right way, we will see someday or the other some patient getting over corrected and going and developing this complication. And that complication is what we call as osmotic demyelination syndrome or central pontine myelinolysis. And this has more of a pseudobulbar palsy like kind of features. No, it has bilateral hypertonia, hyperreflexia, rigidity, sometimes clonus, and those kind of things. And you look into the MRI, and MRI basically to look for ponds. So it's a simple question again. I don't think anybody has any doubt about this. It is a quadriparesis, yeah, mostly, but we have seen more of para or quadriparesis, bilateral conjugate palsy, again midbrain. And what investigation needs to be done? It's a very simple straight pick. And we have discussed about ODs in detail, because when we correct hyponatremia, this is the biggest danger, especially when you don't know the duration of hyponatremia, especially when the hyponatremia is after 48 hours. Whether you have to give the patient 3% NS or not, it depends a lot on this, because once you are in the acute state of hyponatremia, the whole idea is to prevent cerebral edema. So once you know that you have to prevent cerebral edema, giving 3% NS is perfectly okay. But after 48 hours, when there is some kind of compensation that is happening from the side of the brain, yeah, that is basically what is called as the solute excretion, and brain kind of uh, shrinking a little bit in size. If you further give the patient 3% saline, there is a risk of developing osmotic demyelination syndrome. So that is what we have been discussing in detail. And what are the risk factors for ODs? What are the risk factors for cerebral edema? It's an important module. This time around, I think the questions are very easy, but you can get tough questions on SIDH, you can get tough questions on diabetes insipidus, you can get any kind of questions with respect to that. So just like DK management is very important, hyponatremia in the OP setting, not OP setting, IP setting, ICU setting, critical care, everywhere is very important. That is why starting from ADH, we have done different modules on hyponatremia. To know those modules is very important. Okay, then we go to another question, which is salt craving, skin pigmentation, hyponatremia, hyperkalemia, metabolic acidosis. There's no doubt about it, because cons, Cushing's, etc. are all associated with hypo, and we have seen that how it progresses and all that. FeO has nothing to do with this. Addison, I think everybody got right, because of the reason that there was skin pigmentation, and I think then there was no question with respect to it. Salt craving is because of mineralocorticoid insufficiency. Hyponatremia, hyperkalemia is also because of mineralocorticoid insufficiency with acidosis. So it shows that there is glucocorticoid and mineralocorticoid insufficiency, which is primarily a part of what we call as adrenal failure or primary adrenal insufficiency. So it's again a simple question. I think majority got it right. Hyperpigmentation, diagnosis, Addison. What is the reason for this? Is another two easy question, which again is a part of physiology as well. We've discussed a lot about this POMC, and from POMC you have ACTH and MSH and lipotrophins and all that. We've gone to very higher end discussions in the basic part of endocrine, where we've discussed about structural similarity and what happens and all that. So I think this is also a very easy question. Then comes this question on diabetes with the low ejection fraction and all that. This could have been a little bit tough if you had the GLP-1 also in the options, but we don't have any GLP-1 in the option. Pioglitazone and all can worsen your heart failure. Sitagliptin, gliptins have got nothing to do with the heart. They're cardiac neutral. Sulfonyl ureas are actually speaking not so good for the heart, especially glibenclamide and all that. So again, a very straightforward pick, and anybody who's worked in the ward will know that majority of the patients these days are on SGLT2 inhibitors. Many people use DAPA, some people use empagliflozin and all that. Supracellular mass with calcification, wet keratin nodule, a very classical question on craniopharyngioma. I think the age of the patient, I'm not sure exactly what they have asked, but again, you know that when there is a supracellular mass with calcification, with machinery oil, keratin nodules, and all those terms that we generally tend to use with mass effects or stock effect and all that. There's only one answer, and vivid enhancement. Post contrast is very classical. We have done this table. Please go back and see that differences between craniopharyngioma and in children and adults. The child one, which is called as the adamantinomatous craniopharyngioma, and the adult one, which is called as the papillary craniopharyngioma, and all that. And craniopharyngioma versus rat cases. Some people had a doubt with respect to the question being on rat cases. Rat cases is not going to have calcification. Rat cases is not going to have wet keratin nodule. Rat cases is not a supracellular mass. Rat cases will not enhance vividly with contrast. It has a clause and all of the boundaries will actually take up contrast. So I don't know whether there's any confusion with respect to it. So these questions are all very easy. Majority of people got it right. Now we come to the two controversial questions which came this time from endocrine. The first controversial question is on the drug which is used for the treatment of hypertension in pheochromocytoma. Now, hypertension and pheochromocytoma, there are two parts. We are just looking at it, the pre-op part. Now, the preoperative preparation of a patient with pheochromocytoma itself, we know that we start alpha blocker approximately 14 days prior to the surgery, 10 to 14 days prior to the surgery. The best alpha blocker is always phenoxybenzimine, and we have discussed about phenoxybenzimine being started at a dose of 10 milligram and all that. But availability issues and stuff, you can even use the so-called prazosin, terazosin and all that. So these are your options, and you step up the dose, and I've told you how to do it. Now, in case you are not getting adequate blockade with alpha, you can always try the other options. The other options are one, calcium channel blockers and mitarosin. I told you mitarosin is not popular and not available. Calcium channel blockers, amlodipine, nifedipine, nicardipine, all these things can be used. Now, this is the general rule, and 2 to 3 days prior to surgery, to control the heart rate, you start the patient on beta blockers, which are basically oral beta blockers like atenolol, propranolol, and all that. We generally use propranolol, all that I told you. Now, the question, as per what I understand, is the pre-op and intra-op control of hypertension. So, when you look at pre-op, this is what we do pre-op. But can any of these drugs be used for intra-op control of hypertension? Intra-op hypertension in pheochromocytoma is mostly part of a crisis. And I have very clearly mentioned that there are 3 drugs approved for intraoperative control of hypertension in pheochromocytoma. One is IV phentolamine, second is IV sodium nitroprusside, and third is IV nicardipine. These are the only 3 drugs. So if you look at a drug which has role in both the intraop and pre-op control of hypertension in pheochromocytoma, the correct answer is nicardipine, if that is the option. Okay, if they mention CCB, that is also correct. If they mention nifedipine, even that is also right. Because for intra-op control, we do give nifedipine as well. So nifedipine is also an option. But again, nicardipine is the correct answer. But you can never say phenoxybenzpine because phenoxybenzpine has no role in intraoperative control of hypertension in pheochromocytoma. Even if you're showing me a reference otherwise, that is wrong because this is pheo, this is our domain. So we can't agree. So pheo, if the question is on the best drug for preoperative, it is phenoxybenzpine. But I clearly understand that pre and intraoperative is given, then calcium channel blocker is the answer. Nicardipine is the perfect answer. Even if nicardipine is not there, you can try nifedipine. You definitely can't write phenoxybenzpine. Another option was clonidine, which is out of question. And the other option is esmolol. Espanol may be used for intraoperative BP control, and you can see anesthetists using that. We're not talking about that here. We're talking about pheochromocytoma specifically. And pheochromocytoma specifically, as per guidelines and as per what we have seen and as per what we use, intraop and pre-op, this is what we manage. Okay, another question. This is not a controversial question. This is a very, very, very good question. These are the kind of questions which can actually help people to study to a level to cross the bar. Yeah, that is, you're starting a patient on thiazide and then the patient develops stones. Okay, it's a very imaginary kind of a thing. So thiazide is it predisposing you to develop stones? Actually speaking, thiazide and stone is a very, very limited association, but they just want you to know whether you have understood the concepts, which means that if you look at the most common cause of stone, it is hypercalciuria. And hypercalciuria, will you see after thiazide? No, after thiazide, you will see hypocalciuria. So can hypocalciuria produce stones? No, hypocalciuria cannot produce stones. So if a patient with thiazide has to develop a stone, it has to be due to some other mechanism, which is hypocitraturia or hypouricosuriia. Hypocitraturia or hyperuricosuriia, of which after hypercalciuria, the second most important mechanism is hypocitraturia. And hyperuricosuriia can never be seen with thiazide. Thiazides, in fact, increase the uric acid levels. So the only option possible is hypocitraturia. Even if you don't know the mechanism of how thiazides produce hypocitraturia, which is irrelevant here. If you know that thiazides can actually increase the uric acid levels in blood, they can decrease the calcium levels in urine. You'll be able to understand that it can decrease the citrate level in urine and produce stones. So this is one so-called maybe a little tricky kind of a conceptual kind of a question. This one is a tough question, but if you know your basics, you will get it right. So these are 2 questions in endocrine, I feel, where if somebody has studied to one level above, then he will be able to make a difference. I really like this question. This question I didn't like so much because they should have made the wordings maybe a little bit more clear. But anyway, these are the 2 controversial questions. We go to cardiology, which is all about atrial fibrillation. Nothing more, nothing less. Everything they asked about atrial fibrillation. So first question is on 4 hours AFib. So 4 hours AFib meaning that we know the duration, which is less than 2 days now. So you take anticoagulation and stroke and all those things out of the window. So if you have an acute onset AFib, what are you going to do? Acute onset AFib, if you're seeing in a young person who is structurally otherwise having a normal heart and no LA dilatation, you can go for pharmacological cardioversion. So pharmacological cardioversion drugs are not there here in the options, like ibutilide or something like that, which is not there in the options. Then you can actually go for DC cardioversion if the patient is hemodynamically unstable. Here again, there is no hemodynamic instability mentioned. And even if you want to go for a pharmacological cardioversion, first thing that you do to make the patient better is to give something to reduce the rate, which can be any AV nodal blocking agent like a beta blocker or a calcium channel blocker, non-DHP calcium channel blocker. And here the answer is rate control. So basically, any very basic question, just to see whether you have gone near the casualty once in a while, so that you know how to do this. This is something which we all discussed. Now, final year MBBS catch during my times. My chief Jayaprakash sir, who was the HOD of medicine and Kottayam Medical College, he used to tell that his contemporary failed for this. That means whenever you present that case, no, without knowing, you will say low pitch mid diastolic rough rumbling murmur heard in the left lateral position with the bell of the stethoscope. Like that, he would say with the presystolic accentuation, and you finish off that murmur, and finally you remember or the patient has irregular pulse. If you have irregular pulse and then you say pre-systolic accentuation, during those times you used to fail for the MBBS exam. So that's why whenever you are having AFib, you have to be very, very clear that the fact that there will be no P wave on DCG, there will be no A wave on the JVP, there will be no mid-diastolic murmur with pre-systolic accentuation. That pre-systolic accentuation is actually coming from, and no S4 also. No, pre-systolic accentuation is actually coming from where the atrial contraction, which is not going to be there. So that is why pre-systolic accentuation. This many people got it right because it is a basic MBBS level question. Chest discomfort, palpitation, ECG shows PSVT. What is the best drug or prophylaxis of this condition? Again, this is a question where I don't know why some people had some kind of a confusion. I'm very, very sorry if you had confusion. We basically can't think of anything else in this question. See, PSVT, if it is AVNRT, adenosine, and we know how we're giving adenosine and saline chase and all that. We've discussed 6 mg first and then 12 mg later on. Even if you don't know whether it is AVNRT or AVRT or atrial tachycardia, then still you can give a beta blocker, you can give a non-DHP calcium channel blocker. If the patient has a AVNRT, structurally the heart will be normal. So there is no reason to generally put the patient on a prophylactic agent. So there is no reason. And generally this is a one episode and it ends there. But there are people who have AVRT, or there are people who have atrial tachycardia where there is maybe a re-entry circuit going on. So obviously ablation of that is the most important thing. But people who get recurrent episodes are put on drugs which can just control the rate. And that is basically verapamil. If you know that verapamil is part of the treatment plan, if discussed that or seen the video or read the notes itself, I think you should be able to answer this. This is another question which is a normal standard NEET-PG level question. Standard NEET-PG level question where you are having a stroke, patient comes inside the first 2 hours, so window is there, CT brain is done to rule out a bleed, CT angio is not mentioned. So obviously what you have to be doing is a CT angio, and with the CT angio you should see whether the patient has a BP which comes in range, and then if you thrombolize the patient. So we have discussed this. That is the new management of stroke, right? CT angio, thrombolysis. And whether you are going for any intervention later on, yes, you can, depending upon whether it's a first order or second order occlusion and all that. But here again, there is no question, and fortunately, almost everybody got right. So, although the questions are having a clinical background, I don't think any of the students got any of these questions wrong. All these questions were pretty easy and majority of them got it right. Controversial question here in cardiology, I don't know whether it's cardiology or a pathology question, was on this heart failure cells or hemosiderin-laden macrophage, and whether hemosiderin-laden macrophage is seen in all except was the question. Whether right heart failure is the answer or protein-losing enteropathy is the answer. I think even pathologists can actually comment on this. Hemosiderin-laden macrophage is basically part of increased LVEDP, which is equal to increased LAP, which is equal to increased pulmonary venous pressure, which all of you know. And bleeding into the alveoli is where we actually look out for it. And that's why I have discussed the importance of hemosiderin-laden macrophage in pulmonary renal syndromes and vasculitis, basically. Most importantly, with respect to Goodpasture syndrome and all that, where we check for this. But it is definitely part of LV failure. It's definitely part of left heart failure. So you can think that the examiner is just trying to check out whether it is a left or right. So instead of left, he put right. So you can mark the answer as right heart failure. But whether you can get it in protein-losing enteropathy, if the examiner is an intelligent guy, I presume, then the answer for this question is protein-losing enteropathy. Because protein-losing enteropathy, if you look through literature, has never had any association with hemosiderin-laden macrophage. Now, protein-losing enteropathy can help you lose, not help you, can cause loss of protein, which can deplete your intravascular volume and further cause what is called a volume overload, where the fluid will be actually sweeping into the extravascular space. So even if you're having a volume overload in protein-losing enteropathy, that be pleural effusion, pericardial effusion, or ascites. It cannot be pulmonary edema. So obviously there is no question of pulmonary edema there. Right heart failure can be isolated right heart failure, like a restrictive cardiomyopathy. But more commonly, how do you see right heart failure? You see LVEDP equal to pulmonary venous pressure equal to pulmonary RV end diastolic pressure equal to pulmonary capillary pressure. So basically what happens, most of the time the cause for an increase in RVEDP is what? An increase in LAP or an increase in LVEDP. So they are all basically connected. So you can argue that pure right heart failure cannot have this, but then I can argue that from where can you get protein-losing enteropathy, or from where does protein-losing enteropathy come into the picture? It is impossible. So for me, the answer to this question is protein-losing enteropathy. Though pathology people or somebody else can actually kind of, what do you say, argue. But my point is RBC has to come correct. So there has to be a RBC, there has to be hemoglobin released from the RBC, and this has to be taken by the macrophage. So for that, there should be RBC coming into the picture. From where will RBC come into the picture in a protein-losing enteropathy? For that, protein-losing enteropathy should be associated with some systemic sclerosis, and that should be associated with some pulmonary hypertension and all that. Like that, if you want to associate, means you can say that my house is in San Francisco because my uncle went to Los Angeles few years ago. No, that kind of association is not possible. So we have to bring a more logical conclusion. So I feel this way. But another simple way of looking at it is every time it is left heart failure. So this guy has foxed and made it right heart failure. That way also you can think. But my answer to this question will be protein losing enteropathy. So that is about cardiology for this exam. Okay, again to just show you about the calcium channel blockers that we use to control ventricular rate, verapamil, propranolol, and the ones we use. And for cardioversion, we generally use ibutylide, 1 milligram IV over 10 minutes, etc. So that is about the cardiology part. Okay, so we go to the third subject, which is rheumatology. So I told you I can pardon you if you make mistakes in cardio, neuro, and endocrine, because one, cardiology is always tough. I believe that way. Neurology is too vast, so anyone can get any question wrong. Endocrine is got a lot of permutation combinations, very easy to confuse you. Apart from that, liver, gastro, rheumat, and nephrology is not that easy, but still I believe like I discuss in a way that you should be able to answer everything. But liver, gastro, rheumat, I mean, there's no excuse for getting anything wrong, because liver gastro rheumat is what I consider as our zone. I mean, everything is in our zone, but then sometimes the pitch is too hard. You know that the ball is going to bounce or it's going to swing, and invariably at a point you will nick one to the keeper and you'll get out. But liver gastro rheumat is like our own countryside pitch. Yeah, countryside pitch where the ball will not bounce below above knee level. There will be no swing, nothing. It'll be a flat track. There'll be no grass, and the whole day you can just get on top of the bowlers and score. So rheumat is that kind of a subject for us. And this time, I think rheumat questions are very easy. One question is on Sjogren syndrome, which obviously there is no confusion, and immune destruction is the key point. It is a what is Sjogren syndrome? I have told you, what is Sjogren syndrome for a basic MBBS level guy is destruction of the salivary glands. But for us, what we say it's a multi-system autoimmune inflammatory connective tissue disease, which is an autoimmune lymphocytic exocrinopathy with one endocrine organ involved, that is thyroid, and it's a periductal inflammation that we get and all that. So it's basically destruction of the salivary gland due to neutrophilic infiltrate, which is 100% wrong. Malar rash and arthritis wrong. Malar rash is part of SLE. Amyloid deposition is an imagination option, and this is your lymphocytic infiltration. So this is the opening slide that you can see: autoimmune lymphocytic exocrinopathy, which is around the ductal and around the blood vessels and causing activation of the ductal epithelium. Yeah, so there are two parts to it: immune destruction due to the lymphocyte and immune inhibition, which is part of your anticholinergic pathway also. So that's a very easy question. Even if you don't know any of these things, majority of people got it right. This is a question which few people got wrong, but very sorry for them, because if you've seen it and basically got a very basic understanding, it will get it right. So this is a question where the patient has got SCL70 positivity. So topoisomerase 1 positivity. So SCL70 positivity is very much in favor of diffuse scleroderma, which you know that, and anti-centromere antibody positivity is very much in favor of limited scleroderma, so all of you know. Anti-SCL70 is got maximum association with renal and lung. Yeah, these are the two things where anti-SCL70 has got maximum association. And of course, cardiac and tendon friction rupts. If you want to complete, these are the four things which we tend to associate the most with anti-SCL70. Renal is your thrombotic microangiopathy, lung is your ILD, cardiac is your restrictive cardiomyopathy, and tendon friction rupts. This is what you actually associate with what is called as anti-SCL70. Myositis can be seen in scleroderma. This is one issue in scleroderma, which is part of inflammation. Generally, scleroderma is all about fibrosis. Arthritis, myositis you can get in scleroderma, which is a part of inflammation, but more with limited. Gastric antral vascular ectasia is mostly a part of your limited scleroderma, because GIT manifestations in general are part of limited scleroderma, as you know, because it is associated with crest and C's calcinosis cutis, Raynaud's, esophagitis. So along with esophagitis, we've discussed about the different GIT manifestations: the loss of tone of LES, the intestinal pseudo obstruction, the gastric antral vascular ectasia, and all that. Sclerodactyly telangiectasia, so that's what it is. Calcinosis cutis is again a part of the C. It's all part of limited. So they're all just basically part of limited. If Raynaud's phenomenon was there in the option also, it will be wrong because it is also more associated with limited. We discussed, no, long duration Raynaud with critical limb ischemia, ulcers, gangrene, all are part of what limited. So here the answer is very straightforward. Even if you don't know any of these things, you know that diffuse is equal to ILD and limited is equal to pulmonary hypertension. Then also you'll be able to make this answer. And the most dreaded dangerous complication in RA and SLE is MI or ACS because of accelerated atherosclerosis, whereas in scleroderma it is fibrosis. And where does fibrosis happen? It happens in the lungs. So that way also you can actually get this answer, right? So please go back and study these three antibodies. The association of these three antibodies is very, 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 very important. So there is no way you can skip that. And we've discussed this in detail. This is from Kelly and this is from Harrison. So we've discussed the tables in detail. Then morning stiffness and anti-CCP antibody, I think everybody knows RA. And RA is all about synovial hypertrophy and what formation? Pannus formation. So this is very basic pathology part of RA. So everybody got it right. There was a question on acute monoarthritis with synovial fluid showing the crystals which are positively birefringent. And I think everybody got it as CPPD disease, what we call a pseudo gout. But for our students who should know that this is not just pseudo gout, don't call it pseudo gout. I've discussed about the fact that this could be pseudo RA, this could be pseudo OA, this could be pseudo Charcot. It's a pseudo guy. That's what CPPD disease is about. So these are all very basic questions. Then what is pegloticase in pharmacology? What we use in TLS, recombinant urate oxidase, lamellated congregations and giant cells and all that. A basic pathology question on sarcoidosis, caspase dependent pathways. We've discussed about how important caspases are with respect to gout and how gout has evolved itself from a disease associated with pyroptosis and what is interleukin 1 beta and all that. So then pyroptosis and apoptosis are all basically caspase dependent. C5b to C9 deficiency, you got two very interesting questions. I think all of you would have answered that right, because when we discuss about SLE, the first thing that we say is the most important genetic risk factor for SLE is C1q deficiency. So early complement deficiencies are very strongly associated with SLE, whereas late complement deficiencies are very strongly associated with Neisseria, which can be Neisseria gonorrhea-related disseminated gonococcal infection or meningitis. So I think all of you would have answered that. Even in pathology or micro would have studied this, but two very important questions. Then back pain, inflammatory back pain in a young person, what to do? I mean, obviously, we've discussed about the investigation of choice in axial spondyloarthropathy being MRI, and I have gone to the extent of teaching about STIR sequences, where you see short tau inversion recovery sequences, where you get hyperintensities because of bone marrow edema. Fibrillin gene mutation, Marfan syndrome, again, aortic regurgitation side and all that we have discussed about it. It's a very simple, straightforward question. So rheumatology, there are a lot number of questions, but all the questions are basically speaking very easy. So only one question which few people got wrong is this, but that is due to your, what do you say, pure revision or not enough depth in understanding. But generally, I think all of you would have got everything right. This is the problem. Margins are very narrow. If you look at the question so far, you will understand what differentiates somebody who has studied properly from somebody who has had very superficial learning. It's just 3 or 4 questions. So margins are very narrow. So we go to neurology now. So neurology comes the first controversial question, which is on prophylaxis of migraine. So first line prophylactic drugs for migraine, of course, you have topiramate and you have propranolol. So the question comes as to whether you want to choose topiramate or you want to choose propranolol. Now, this is a straight pick USMLE question. So in a USMLE question bank, you can see this question and the answer to the question given there is propranolol. Now, the only confusion is if chest tightness is mentioned. If chest tightness is mentioned and that is not in association with triptan, if the question mentions that the patient has got chest tightness after taking triptan, then you can attribute it to triptan. Family history of CAD or the patient herself having CAD or the patient having angina, whatever, still propranolol remains the drug of choice. Propranolol is out only if your patient is have proven COPD or the patient has a proven bronchial asthma or has tightness on and off chest tightness and not diagnosed asthma. So when nothing of that kind is mentioned here, you probably have to go with the answer propranolol. But again, I'm not sure with this because it depends on the wordings of the question. If the wordings of the question mention the patient to be not a candidate for propranolol, something like enough, I mean, on and off patient has chest tightness, on and off had respiratory issues, like that if mentioned, you probably can go for topiramate. Otherwise, you can stick with propranolol. I feel because this question is a straight pick from a USMLE Western Bank, I think there also the answer was propranolol. So probably here also the answer will be propranolol. 30-year-old female finds weakness in right hand, and this is a very, very basic question. Like if you look into the approach of LMN, you know that our approach to LMN, we start from the anterogrons, then we go to the root, and then we go to the plexus, and then we go to the nerve and neuromuscular junction and muscle. So a very straightforward anterogronsal issue. where you're having element. All the others are basically human things. So simple question. Diabetes and neuropathy. What kind of neuropathy you get in diabetes? You don't have to read the question even. Diabetes will have a symmetrical small fiber, sensory more than motor, polyneuropathy, which is a distal to proximal axonal neuropathy, which is the people wrongly call it as the glove and stocking. Should actually call it as the stocking and glove pattern. Glove and stocking is for cervical myelopathy. Stocking and glove pattern is what we see for diabetic neuropathy. So again, these are all questions which everybody got right. And hydrochlorothiazide, cerebellar ataxia, horizontal nystagmus, and all that with respect to thiamine, another easy question. So basically, neurology questions. These are two questions which I think just to final year MBBS level knowledge is required. This is the one question which many people found controversial, and this is not related to knowledge. It's just luck. If you write topiramate and it happens to be propranolol, it's bad luck. That's all. If you write propranolol and it happens to be topiramate, that's also bad luck. So I feel still it's propranolol mostly because there is no particular reason to not write propranolol because it's the most commonly used. Okay, we go to nephrology. This is another question which again, these are the kind of questions you expect because it tests the student. So net capillary, net hydrostatic pressure minus net oncotic pressure is your um, net ultrafiltration pressure, which into ultrafiltration coefficient is your GFR. So net hydrostatic pressure should be equal to your capillary hydrostatic pressure minus interstitial hydrostatic pressure. Net oncotic pressure should be your capillary oncotic pressure minus interstitial oncotic pressure. This should be the way it is. Capillary hydrostatic pressure is equal to uh, 18 millimeters. Interstitial hydrostatic pressure is the one in question. Minus capillary oncotic pressure is equal to 27 millimeters, and interstitial oncotic pressure is equal to 7. And they've given that the ultrafiltration is 0, which means 18 minus x minus 20 is equal to 0. So 18 minus x is equal to 20, or x is equal to 18 minus 20. X is equal to minus 2. Yes. So memories of your school mathematics. So x is equal to minus 2 millimeters of mercury. This is a question I like. These are the kind of questions which test you at least. Yeah. This is a question where people have asked you about acidosis, alkalosis question. pH is 7.3, so it is acidosis. Don't read the question, just with the ABG we'll get there. PCO2 is 44, so it is elevated. So that is a respiratory component is actually going in the lines of acidosis. Then bicarbonate is 16, so that is decreasing. So that is again going in the lines of acidosis. So this looks like respiratory and metabolic. So whenever you have a doubt like that, what do? You look for the percentage change, which is more significant. That means 44 minus 40 by 40 is the change in respiratory. 24 minus 16 by 24 is the change for metabolic. So 44 minus 40 by 40 is how much? It is just 4 by 40, which is it's just 0.1. Whereas here it is 8 by 24, which is actually speaking more than 0.3. So the more significant change is for metabolic, which means it is a metabolic acidosis question. Acute metabolic acidosis, I don't know why that fellow is mentioned like that, nothing like that. And anion gap is 132 sodium minus 86 plus 16. So this is basically what is your anion gap. Correct. So simple question. I don't think again anybody got this wrong. Crystalloid infusion given in large doses likely to produce hyperchloremic acidosis. I think I've discussed this in detail. No, under sepsis and AK, is normal saline mean really normal? That is the heading of that. Like means is normal saline really normal? Means normal saline is not really normal because of the reason that if it can actually produce hyperchloremia and hyperchloremia related acidosis because it is not having a chloride concentration which is mimicking that of the plasma. So plasma has 105 to 109. It's why ringer lactate for large volume infusions are considered to be better. There are a lot of studies coming that way. And DNS also you can argue has got the same amount of sodium, but nobody gives DNS for large quantities, to actually, reperfuse the patient. Nobody gives DNS. So it's NS only, and I think majority of people got this question right. Shortness of breath, again, the question on pH of 7.22, PCO2 66. So respiratory acidosis question, not much of doubt. This is the pathogenesis of hyperchloremic acidosis. Again, if you want, you can actually go and read that, but I don't think it's that significant. Everybody got it right. Two controversial questions in nephrology. First controversial question is CKD with anemia. CKD with anemia, some people saying first line management or most appropriate management or most effective management. First line management is always IV iron, but most appropriate, most effective is always EPO or darbepoetin alpha as it was given in the options, because the most important reason for anemia in CKD is subnormal levels of EPO. Uremic inhibitors of erythropoiesis. Because of uremic inhibitors of erythropoiesis, enough of EPO that is required to sustain for that level of hypoxia is not produced. So subnormal EPO production, which is basically the reason for the anemia. So if you are asked most effective, most appropriate, etc., the answer is DARB or erythropoietin. But in case they ask you, but the first step is always iron estimation, and iron that I think most people got right. Then this controversial question on CKD MBD in a child. So this is a question on CKD MBD in a child. CKD MBD in a child is a typical CKD MBD question with low calcium, high phosphorus, low D3, and increased PTH. All these things. This is a typical CKD MBD question. What do you do for CKD MBD in a child? CKD MBD in a child, I think I have discussed about CKD MBD in adult in detail, but generally phosphorus control is the most important thing because the killer ion is phosphorus. Phosphorus is the one that converts normal vascular endothelial cells into osteoblasts, and that can trap calcium, and that can lead to irreversible calcification and all that we have seen. So the king ion is always phosphorus. So how do you kind of tackle phosphorus? Is dietary phosphate restriction and use something which can actually kind of bind phosphorus. It's very simple terms. In adult, we have so many options, like from sucroferrioxide hydroxide to tenapanor to sevelamer to all those options are there. In a child, when you see those pure phosphate binders, we don't have much of data on that and not generally preferred. The phosphate binders that we use in a child is calcium acetate. This is the common phosphate binder which you see all the people actually using in a child. So calcium acetate. But child basically means you have to give vitamin D because the most potent inhibitor of parathormone is vitamin D. So vitamin D should inhibit parathormone. So there is no reason why you can't give vitamin D unless and until you are given that vitamin D levels are normal, which cannot be there in this case. So vitamin D3 or calcitriol has to be given to this patient. So vitamin D3 plus calcium acetate would be the correct option. But they've given vitamin D plus calcium supplements. I don't know whether they meant calcium acetate, but there is no option but to mark this. Pure phosphate binder has no role here. Calcium supplementation and phosphate binder, again, there is no reason because the phosphate binder you're using is itself having calcium. So there is no reason to actually supplement calcium. Vitamin D has to be given in all these children, especially CKD MBD in a child, unless and until the child has normal vitamin D levels, which they've not mentioned. So out of that much understanding, I think this is what it is. I think so some people are misguided by the fact that vitamin D will increase phosphorus. No. Please go back and watch the module. That is true, but not in this context. This context is all about CKD MBD. CKD MBD, the kinetics are different because parathormone is elevated. Okay. So this is not a really good question. They should have given better options, but still, I think people who have studied might actually get this one right. So this is the only one question which you can feel kind of in the zone. Then comes hematology questions, all very easy. CD10 and BCL2 itself means, germinal center, centrocyte, centroblast, and germinal center is actually making the noise, and germinal center is all about follicular lymphoma, 14-18 translocation and all. I think all of you know this. There is no reason to discuss. Then we have this I don't know whether they actually gave you faggot cells which have this clustering of ore rods and stuff. I think that was the option. So probably 15-17 translocation or PML RAR alpha translocation is what they're looking for, and that's what I think students have also got it right. This is one question which again is a little good kind of. This is a standard question. Factor 9 deficiency is there, because of which somebody's APTT is prolonged. And what is the reason for this APTT getting corrected? Okay, this APTT is getting corrected on giving vitamin K. So giving vitamin K. So hepatitis A has nothing to do with this. Hemophilia has again nothing to do with this. Pernicious anemia again has nothing to do with this. But correction meaning that there should be some reversible cause. So vitamin A, D, E, K is fat soluble vitamin absorption pathway we have seen, and vitamin K comes into the second part of the duodenum, second part of the jejunum through this biliary pathway. So any biliary obstruction meaning it may not come, and when you are actually giving vitamin K, it gets corrected. So it may be a malabsorption, and that malabsorption you have to link with this. So this is a standard question. I think again majority of you would have got it right. What is investigation CD markers? Whatever it is I told you, after morphology, cytology, then immunophenotyping, cytogenetics, molecular genetics. The moment you have a morphology issue, then if you want to confirm, you need CD markers, that is flow cytometry, that is done with the help of immunophenotyping. So it's like very, very basic. Remaining few questions we have all are very straightforward. So out of the majority questions that we've discussed so far, I think right? All are generally very easy. There are only few defining questions here and there, but those are going to make the big difference when the results are out. Let's see this. This is again something that we have discussed so many times that in bronchial asthma, it is the era of LABA and ICS, LABA and ICS, LABA and ICS, and then further you can step up to LABA, LAMA and ICS. So we discuss this in detail, how SABA has gone out of favor and how steroids have gone out of favor in COPD, etc. Then this is a routine question. Start ART after 2 weeks of If it is less than 50 CD4 count, you can start within 2 weeks. If it is 50 more than 50 CD4 count, you can actually start between 2 to 8 weeks. This is another controversial question where we don't know the exact X-ray. I'm not sure. What I can tell you is that if this is a full white out lung with the fissure elevated and trachea shifted to the opposite side, sorry, same side, then you can mark it as collapse. But the question actually had an ongoing consolidation with a shift in trachea, which could be a normal deviation with air bronchogram, is what the students are saying. So if that is the case, you mark it as consolidation. Clinical picture is like consolidation with a minimal tracheal shift and you're seeing air bronchogram, then it is consolidation only. Clinical picture is like prolonged consolidation with a major shift, with the whiteout lung, with the fissure elevated, you can mark it as collapse. I'm not exactly sure what they wanted as the answer, but I feel this image is not the image that you have to see, because we just put it up. Original image, we have no idea, but original image, I feel, is consolidation image, is what most of the students are telling us. Okay, rifampicin resistance, yes, this is the BPAM regimen. All don't read too much into it. This is BPAM. There are people who are actioning with this miliary TB or whatever. We are not changing the answer by any means, unless and until it is some disseminated tuberculosis with some CNS involvement and all that. Here it is BPAM. CT pulmonary angio for pulmonary embolism. Again, everybody got it right. Hereditary spherocytosis for a question with a family history, and a hemolytic anemia question. Hemolytic anemia, again, approach and how to look at it from the angle of compensated or a decompensated or a one where you are having inherited versus acquired. All those things we have seen enough and more. Macrocytosis and B12 deficiency, again, nothing much to think about. Antimitochondrial antibody positive and primary biliary cholangitis, again, nothing much to think about. So all these are very, very, very easy picks. And finally, DVT prophylaxis, low molecular weight heparin, factor 9 deficiency question I told you. Contraction of LDS with increased emptying and metoclopramide. Wheels disease, very simple question. Campylobacter jejuni and raw milk and gram-negative rods. Nocardiosis, one basic question. Branching septate, IP, aspergillosis, CT pulmonary angio, IgA dermatitis herpetiformis, gluten enteropathy. All these are the other questions. I think all are very, very easy. Total around 65 questions we have. I discussed almost all of them. So very few controversial questions here and there. Maximum 5 controversial questions is what we have, and 5 questions which may actually kind of what do you say, decide your fortunes. But what I can tell you is that this is one exam. You take it as one of its kind, and may come in this format again, may not come in this format again. But our basic aim, why we have actually taken up this course and why we are actually doing this course, in spite of so much of negativity around and so much of negativity being spread by so many people about the course. If you take Insta for 5 minutes and looking through the reels, you can see the struggles that an MBBS student is undergoing. It's like I myself think as to, my God, what a heck of a course this is. Why there's so much of negative propaganda about this? At one side, 25 lakh people are appearing for NEET-UG and there is considerable demand. On the other side, people who have joined the course are feeling extraordinarily disappointed, devastated, frustrated, feeling that they're not moving anywhere in life, to the extent that there is something called as mid-20 crisis now. Mid-20 crisis is a very popular terminology on social media, which includes everything from not having income to losing hair to hundreds of things. So I personally feel that is because of the fact that you fail to realize this is like running a 10,000 meter marathon race. In a 10,000 meter marathon race, there are only two things that can disqualify you. One, if you change your lap. If you change your lap, then you will be disqualified. Nobody is going to question you for the speed that which you are running. So you can run as slow as you want. You can run fast at times, you can run slow at times, you can run whichever way you want. But the moment you change your lap, or the moment you actually go out, take rest and come back, you are not going to be in the race. So you have to be running in that lap, consistently in that lap, at speeds which you decide, at times fast, at times slow. And as the Japanese say, 3 minutes of fast walking plus 3 minutes of slow walking is basically what is the most ideal one. So essentially, that is what we do in this. Competition is sky high, but still there are seats. The point is whether you get the seat that you really want in the place that you really want. So that is the whole thing. But still, believe me, there are enough seats. So it's not like the seats are far few. No, it's not that way. You are having seats, and this exam is not keeping up with any pattern. But finally, my most important statement is not leveling up is too risky. You have to level up. There is no other way out, because if you look at the people who are joining MBBS now, especially in the last 2 or 3 years, they are using the platform from first year itself. They are learning and learning and learning. Even in private colleges, there is a very strong urge for students from within inside to learn and to level up. So people who are maybe like passed out now and have not done that leveling up till now may completely be sidelined from the mainstream. So for them, it is very important to pull up their socks and start running. It is heavy competition. Every time it's been like that. So positive thoughts, positive thinking, and looking forward to the results, as well as for people who are not able to make it through, just continue with the good work, continue with your efforts, and invariably at a point in time, you will cross the bar. But more important from our side is always leveling up. Thank you.